Good evening, everyone. I want to welcome you to this Scleral Lens Education Society's presentation, Customizing Scleral Lenses, with the great Dottie Fidel and Melissa Barnett. Dr. Dottie Fidel is a contact lens designer, a pioneer of modern lens designs, and a specialist in contact lenses for irregular corneas, scleral lenses, myopia control, and orthokeratology. She actually speaks 5 languages. She studied optometry in Rome, a 4-year course that she achieved in 3 years with honors. She started to lecture and published from her first year of optometry school. She has 20+ years experience in optometry and specialty contact lenses. She runs an optometric practice specializing in contact lenses in Italy, where she personally designs and fits special customized contact lenses. She is internationally recognized as a key opinion leader who has several peer-reviewed publications in the area of specialty contact lenses and is a speaker in national and international symposia. Dottie Fidel and Dr. Melissa Barnett are authors of Clinical Guide for Scleral Lenses. She is the first certified Iprint practitioner outside of the USA and Canada. Fidel is a fellow of the Scleral Lens Education Society and the British Contact Lens Association. She is the founder and immediate past president of Accademia Italiana Lenti Sclerali, co-founder and president of Euro and Australia Asia Scleral Lens Academy Council, also of the Council of International Society of Contact Lens Specialists. She's a member of the Medical Advisory Board of the International Keratoconus Academy, Program and Education Chair of the Summit of Specialty Contact Lenses, and of the Global Ophthalmic Women. She's a board member of the International Forum for Scleral Lens Research and of the International Congress of Scleral Contacts. She's a clinical advisor of myopia care, International Relations Chair of the Scleral Lens Education Society, and a member of the International Association of Contact Lens Educators. Our other presenter, Dr. Melissa Barnett, is a principal optometrist at University of California, Davis Eye Center in Sacramento and Davis, California. She is an internationally recognized key opinion leader specializing in dry eye disease and specialty contact lenses. Dr. Barnett lectures globally and publishes extensively on topics including dry eye, anterior segment disease, contact lenses, and creating a healthy balance between work and home life for women in optometry. She is a fellow of the American Academy of Optometry, a diplomat of the American Board of Certification in Medical Optometry, a fellow of the British Contact Lens Association, and she serves on the board of the American Optometric Association Contact Lens and Cornea Section, the Gas Permeable Lens Institute, the International Society of Contact Lens Specialists, and is the past president of the Scleral Lens Education Society. Dr. Melissa Barnett and Lynette Johns authored and edited the book Contemporary Scleral Lenses, Theory and Application, with unique perspectives and contributions of international experts. Dr. Barnett was awarded the inaugural Thea Award for Excellence for Mentoring by Women in Optometry. She was granted the most influential woman in Optical from Vision Monday in 2019. Dr. Barnett and Tom Arnold are co-hosts of the popular podcast Globalize. In her spare time, she enjoys cooking, yoga, hiking, spending time with family. Todd Erickson, who is also an optometrist, and their 2 sons, Alex and Drew. And with that, I will turn it over to our presenters.
Well, thank you, Drew, for the warm welcome, and really thank you to the Scleral Lens Education Society for having us tonight, and thank you for all of you for being here as well. It's an honor to be speaking on this topic. So both Dottie and I have some disclosures that we would like to share with all of you. This presentation includes many different companies, but we're absolutely thrilled to be with you here tonight. So let's start with the Visser's work, and Simone Visser and team really started with this instrumental study and showed the advantages of toric scleral lenses. So scleral lenses with back surface toricity were actually rotated on the eye, and the amount of time it took for them to go back into the position was measured. And from this study, it was found that back surface toricity, different from front toric, of course, patients found that they were more comfortable and experienced better vision with toric scleral lenses. Now, there were also other advantages too: less fogging, more comfortable wearing time. And that was a really instrumental study. I remember when that came out and I thought, wow, that's absolutely amazing, because years ago we were not incorporating toricity into scleral lenses, nothing like we're doing today. And this lecture is going to cover a lot of what we're doing today and what's coming even right now and in a few months. It's very exciting. Greg Denayer and team with the Scleral study group, the Scleral Shape Study Group, analyzed 140 patients and looked at their scleral shape. And this study also really stood out. Of course, I'm not covering every single study that's out there. I'm just highlighting a few of them so we can start the discussion here. But for spherical eyes, only 5.7% of eyes are actually spherical. And when we think about this, let's think about it when we're fitting scleral lenses. If only 5.7% have spherical eyes, the majority of our lenses that we're fitting should not be spherical. Again, I'm talking about the back surface. Going back to their study, 28% had a regular toric appearance, and more than 40% had asymmetry, so different high points and different low points for scleral shape. And interestingly enough, 25% had irregular shapes, so not necessarily regular toric, not asymmetrical, but unique shapes that would require unique lenses. So if you look at groups 3 and 4, this accounts for about 66% of eyes that require a very customized design for their scleral lens. So going back to Denayer's study, there are 4 primary categories of scleral shape. And from this study, it showed that the measurement of the sclera is really important. And we know that once we start fitting scleral lenses, we find all sorts of things, even like a pinguecula, which are really incredibly common. We find that eyes are not necessarily the shape that we thought that they were before we started measuring them. And this study suggests that the majority of eyes can really benefit from a custom back surface lens beyond just a regular standard toric design. Moving on to another study. So this is looking at the corneoscleral profile, and it evaluated the limbal scleral radii that were measured with OCT for this study in 8 different meridians, and evaluated the relationship between the central radii, corneal eccentricity, and scleral radii, and found that the meridian measured across 45 degrees was significantly flatter in the image in the picture you can see up right than all of the other meridians. So this corresponds to other studies that have been previously published as well, that the nasal scleral radii are significantly flatter than temporal scleral radii. However, there is no statistically significant correlation between corneal eccentricity and scleral radii in each meridian. And the bottom image you can see is a patient with keratoconus measured with the ESP. So corneal and scleral toricity, this question has been coming up for years. Is it correlated? Is it not correlated? And it was shown that it's really not correlated. And I find just scleral lens fitting these days so fascinating. I take a pentacam of their cornea, then I can measure their sclera, and I can, have these unique discussions. I find every patient is so incredibly unique, as we know when we fit scleral lenses. So in healthy eyes with minimal astigmatism, it's not correlated, both the corneal and scleral toricity. In those patients who have high astigmatism, and especially for patients who have irregular corneas, the sclera shows more irregularity. So the way that I process this information is thinking, well, if I'm fitting a patient who has, say, severe dry eye and Sjogren's, not graft versus host disease or something like that, they might have a more normal or regular scleral shape, or they might not, depending on what else they might have going on, maybe a pterygium, maybe they've had glaucoma surgery, versus a patient who has, say, advanced keratoconus with a lot of corneal irregularity. They might have a more irregular scleral shape and more scleral toricity. The corneoscleral junction angle also varies with age and varies between ethnicities. And as you can see on the image on the right here, this is looking at Asians and Caucasians and shows the difference between the significant parts, which are in blue, and the non-significant areas, which are in red, plotted along a contour line. So Caucasians have a higher angle and a rougher surface, I find that fascinating, of the corneoscleral junction compared to Asians and Latinos. And also Asians tend to have a more prolate corneal shape factor along the vertical meridian, a smaller corneal diameter, and a smaller vertical palpebral aperture. So there are some lens designs, and here is an example of one of them, specific lens designs for specific populations. This one, for example, is for Asian eyes, where it's a smaller lens diameter. It has a modified paracentral geometry. And if we just go back to the other slide, I think, what is coming? Right here is what we have now, but there's so much potential of really customized lenses for different people, because we want to make the best lens that we can for every single patient. And as Don Ezekiel always says, we have to do better for our patients. We might fit them in a lens, and I've seen this time and time again, where I think the lens actually looks pretty good, and the vision is good, the comfort is good. I take the lens off, there's no staining of the cornea, there's no staining of the scleral conjunctiva. But once I can modify the lens and make it more precise for the patient, it's really that wow factor, and that I can do better for my patients.
So yes, clinically, why skull lens? I would say skull lenses are progressively gaining popularity among practitioners because of the wide range of their indication benefits, and there are several aspects of skull lenses that still represent challenges clinically, and we don't know how to manage them and get the right way to have a good fitting. Also, each eye is unique and has a distinct surface profile. A generic lens can never be an adequate substitute of a custom specialized lens, which is fabricated for each individual eye. So the first step, okay, thank you. The first step in designing a custom lens involves making accurate digital scans of the shape of the eye. There are different technologies for skull lens customization. We can see some of them here in this slide. Next, Melissa, please. So clinicians should have at least one of these techniques to provide optimized vision and to achieve fitting success and comfort when wearing skull lenses. When is it necessary to customize your skull lenses? Next. In my opinion, always. I personally personalize all my skull lenses. Why do I do that? As you already stated, Melissa. Next, please. Evidence showed that 65.7% of eyes have scleral shapes that are different from commonly designed spherical or toric haptic design. So if you want to well fit most of the eyes of your patients, you need to fit asymmetric lenses. And here you are building an advanced skull lens practice, which is based on asymmetric skull lenses and customization fitting for every single eye. So what we are doing here is tailoring every lens, and you need technology that allows you to map the entire eye and to customize skull lenses. Next, please. Another reason for customizing scleral lenses is because patients ask for advanced technology. They ask for custom scleral lenses. Here are some messages I receive from patients from around the world who want scleral lenses, but they want them made with advanced technology. So they don't only want scleral lenses, they want scleral lenses made with advanced technology, customized scleral lenses, and they are available to travel to find the technology they are asking for. Next, please.
So let's talk about the different technologies that are out there. And it's really an exciting time, I would say, as far as the technologies, even compared to a few years ago, even compared to 5 years ago. And I'm really excited for what the future is going to hold as well. So starting with the Eaglet Eye ESP. So this is an ocular surface imager. It's a raster stereography device where patients look in primary gaze. It's a reflection method, and a very highly viscous drop is instilled, and then fluorescein is needed. And for all of these instruments, good data is very important. We've all heard the term garbage in, garbage out. We want the best scans possible to get the best information. So with the ESP, there's the capability of identifying the best scans, and the staff can do that for you. They can put a star next to it. So with this technology, there's software that has 14 different maps, more than 18 parameters, 2 calculators, and 500,000 data points with incredible accuracy, both of the cornea and the sclera. There are also first fit algorithms that can be used, and a direct connect to different manufacturers. There are more than 40 lenses from 18 or more labs that can be directly connected with the ESP. The Visionary Optics S-Map 3D takes maps in different directions of gaze. So up gaze, down gaze, straight ahead, and stitches those maps together. Again, fluorescein is needed. It's a reflection device. And this image can go out for more than 22 millimeters, covers the entire eye with over 1 million measurement points and a 10 micron precision, which is really quite incredible. This information is exported to the lab. Both standard and freeform lenses can be designed, and there's software for fitting customized lenses from the S-Map 3D. The Oculus Pentacam CSP is different from the other two. So an image is taken in primary gaze. There are more than 250 images. This is using Schleimflug technology, and fluorescein is not required and it should not be used for these measurements. The diameter goes up to 18 millimeters. Lenses can be exported, and different designs from different companies can also be used. In addition, with the CSP technology, there are additional measurements that can be taken, such as the Pentacam imaging itself, also things like horizontal white to white, scans of different areas and elevation, and scleral lenses can be fit, of course, using all 3 of these technologies. So really, a question that comes up all the time is, which one should I get? And, which one is the best? I would say get your hands on whatever you can. And if you can have more than one, that's fantastic. Sort of look at what you're fitting, look at your patient population. But I would say that all 3 of these instruments are incredible and provide so much data with so much accuracy. It's really quite amazing. Many of us have OCT and use anterior segment OCT in our practices to fit scleral lenses. And of course, you can use it when fitting diagnostically. Of course, it's important to let the lens settle into the scleral conjunctiva prior to taking OCT measurements to get a really accurate measurement. And you can check centrally, you can check peripherally. Here's some really nice images from Chris Sint looking at the OCT one, the top one, which is landing on the limbus, and the bottom one, which is ideally landing past the limbus. I would encourage you to also look with the slit lamp too when you're fitting these lenses. don't just use the OCT, because what if the file doesn't save, or what if you didn't get a good look? So correlate that. When I go into practices, I love doing this. And I teach doctors. When we used to have workshops live, how wonderful. I'd always have the doctors and practitioners look at the lens first, then go over to the OCT and compare. So it's a really nice tool when we're fitting scleral lenses. Now there are so many different freeform designs that are becoming available too, so really super exciting. So the top one, the Iprint Pro Scan Fit Pro, is using the different technologies such as ESP or CSP to create a custom lens, and that's that top right image that you can see there. The Visionary Optics Latitude is the bottom right image, where the S-map is taking an image and the latitude lens is designed. Wave scleral lenses can do this exceedingly well also. And very new is the Boston Sight Scleral IG Freeform. The image on the bottom left is using the ESP with the Boston Sight lens, and the Pentacam CSP is coming very soon to design these freeform lenses. Of course, we also have impression-based devices such as Iprint Pro, which we know are incredibly customized. So no anesthetic is needed. It takes about 2 minutes, 1 minute to set up, 1 minute on the eye. It captures very precise curvatures of the entire ocular surface and within 2 microns of accuracy. And it can be used really for anyone. I want to thank John Gelles for these gorgeous images. Here you can see in primary gaze, this is just a beautiful impression. And here you can see the scanning technology and the design of the lens, which you can actually get these images, which is just absolutely amazing. And then very customized lenses are made. So for my patients that have large blebs or have huge irregularities, it's really been helpful to have these very, very customized lenses where other lenses won't clear that area that I want to. And I say that they're incredibly customized, like any custom glove or dress or whatever it might be, depending on which patient I'm talking to. So here's some other just beautiful images. And this is an option that I always like to talk to my patients about, that if they're in, say, a scleral lens that is doing the job, but they're having some sort of complaint, or we could get a better fit, but especially if my patients have a glaucoma drainage device, or if they have multiple irregularities on the scleral conjunctiva, I do talk to them about impression-based devices to make it as customized for them as possible. A really common example is someone who's getting ocular injection with their scleral lenses. So they may or may not be bothered by it. They don't have any edema, they don't have any staining, but the lens is just not fitting them as custom as it could, and you could switch over to really any one of these technologies in order to customize the lens and get a better fit, which often leads to better vision as well. So a recent multi-center review was done of impression-based scleral lenses, and this study was a retrospective chart review study from 2013 to 2019 in 3 specialty contact lens practices. A total of 70 eyes were included in this study, and the primary indications were corneal irregularity and ocular surface disease. 29 patients had unsuccessfully attempted to wear standard scleral lenses prior to being fit with impression-based devices, and there was a significant improvement in visual acuity. An average of 4 visits were needed, including the fitting visit. And the authors of this study determined that impression-based devices can be used for visual and therapeutic success in patients who have very complex eye diseases and who are unable to wear kind of standard scleral lenses.
So yes, I'm gonna talk about this topographer because in Europe we have only this one, unfortunately. As topographer, we don't have SMAP 3D topographer. So Scleral topographer allows you to send the different to different labs the Scleral lens topography, and they can customize the lens in empirical fitting. This Scleral topographer allows you also to speed up the first visit and immediately select the first diagnostic lens to fit. It takes all the measurement and automatically calculates the sagittal height of the first trial lens. It helps to save time during the first visit, which is very important. So let's see here an experiment I did with this instrument. Here we have a topography of an eye. So in this case, I selected the lens diameter of the software, and the software calculated the sagittal height of the first diagnostic lens. It also indicates if the lens needs toricity or asymmetry. So the sagittal calculated was 4,300 microns. What I did is to take a lens from the diagnostic set. Next, Melissa. So the lens I took from the diagnostic set was nearest to the one calculated. I took 4,200 microns, and here are the results of the eye. We can see an optimal lens alignment in all quadrants. Next, please. But the volt is insufficient. So at this point, I took a lens with a greater sagittal height. Next, please. And the lens was well fitted. It was well aligned, and the volt was optimal. So we can see here. Next, please. Okay, here we have the comparison between the first lens and the second one. The clearance between the corner clearance between the both lenses. Next, please. Then I wanted to increase the volt and see what happens. The volt was significantly increased, as you can see in these pictures. So here again, we are seeing the central and mid-peripheral corneal volt. Next. And here the peripheral volt near the limbus. So I personally, next please, I developed my own rule of the thumb based on the volt that the software indicates. This depends also on the diagnostic lens set that you have. So I start with the closest lens with the highest sagittal height, which lead me directly to the lens which will have the correct volt, corneal volt. So next, please.
Dottie, may I highlight your excellent point there of selecting the lens with a higher sagittal height? Because if the lens is touching the cornea, and even say more so than your 4,200 micron lens, it's really difficult to know how much it's touching the cornea. But if you have excessive clearance, you can always come down and you can always reduce the clearance and measure that. And it's easier to tell how much you can reduce it versus if it's touching the cornea.
Definitely. Okay, next please. So in lens customization, how can the technology help in case of pinguecula? Fitting a small scale lens. Next please. The pinguecula will significantly lift off the lens from the ocular surface. So in these cases, we can design a large lens. Next, please. Slightly compressing the pinguecula. However, when the pinguecula is high, it will still lift the lens off. And here, the dark shadow you can see behind the lens edge show the lens fitting. The lens is lifting off. And compressing the pinguecula. Next, please. This may cause important compression, and at lens removal, we will have rebound hyperemia. So in some cases, also the pinguecula will be inflamed from the lens edge. Next, please. What can the technology help us? How the technology can help us with pinguecula? With software, every software will indicate the precise location of the pinguecula and its height, and you have to provide the lab this information. They are very important to the lab to include a localized volt or customized lens periphery. Next, please. The same thing for other conjunctival irregularities. Customized lenses that align properly are necessary in these cases to prevent important complication and adverse event. Next, please. Okay, so we are talking about conjunctival customization, but what about corneal irregularities compromising the fitting? Like in this case of Dr. Reef, where a scleral lens with a localized vault of increased elevation in the peripheral corneal zone was designed for a patient with subsequent nodular degeneration. Here, the upper figure, you can see a view of the lens with a localized vault in the peripheral corneal area, and the optic session observation showing the clearance in the increased vaulting area. And here the OCT image, it shows the scleral lens applied on the eye, showing the localized vaulting over the elevated corneal area. Next, please. Other customizations include fenestration. Remember that fenestration may be included in the corneal area, but also in the scleral areas. The two different types of fenestration are indicated for different problems, and the lens fitting when including them is different. When fenestration is in the limbal area, the lens need a back surface area that relates very closely to the corneal shape. The central vault should not exceed 100-150 microns, and the limbal vault needs to be at least 75-100 microns. Fenestration in the scleral area are indicated to reduce lens suction. In this case, the lens should have a looser fit on the conjunctival tissue to avoid the conjunctival sticking in the holes. And here, Melissa has presented her case. Melissa, would you like to illustrate it?
Right, I think that's a really good point about how we're fitting lenses. And in some cases, I purposely fit lenses that are looser. So this is just a picture of a fenestration, but it's a really interesting case that was referred to me. She comes from about 4 hours away, and she had trauma. She was kicked in the eye with a horse like 40 years before I saw her. So many years ago. She had tried corneal gas permeable lenses, wasn't able to achieve good vision with the lens actually staying on the eye. It would always dislodge. And so she's had a few different corneal transplants over the years, and I was really worried about her cornea. Even when I saw her, I thought, oh no, she did have a little bit of pre-existing edema prior to fitting, which I don't really love to fit, but this was her only option. So she's been wearing a lens with fenestrations now for many years, and she's been very successful. She is using a steroid drop. She also does have glaucoma, so she's followed by an outside corneal specialist and a glaucoma specialist that I'm in communication with. Because it's an eye that I'm concerned about. But she is so incredibly happy because she now has not only improved central vision, which is about 20/25, but really she's noticed her peripheral vision and her depth perception has improved. And she still rides horses, and she's just a lovely woman in her 70s. And so it's really helped her quality of life. So when you have a patient, especially a patient who may have had one or more corneal transplants or a cornea that you're really concerned about, I would encourage you to fit the lens a little looser, consider channels, consider fenestrations, consider, making that lens tolerable so the patient can wear it successfully all day long without compromising their ocular health.
Next. So you introduced channels. Indeed, we can include channel to reduce lens suction and increase tear exchange, avoiding or managing corneal edema. Channels may be ordered to the lab directly. Here we have on your right, we have handmade channels made by Hugo Legaria from Argentina. Next, please. Lens centration is crucial for visual outcomes. We know that lens centration will cause vertical coma. This is very important to consider, especially in cases who have already coma and other high order aberrations like in keratoconus. Optic decentration is also important for multifocal contact lenses. Here are lenses from Christine Saint on your right. These lenses are showing, the first lens is showing a decentered lens, compromising vision. So in this case, Christine designed a lens decentered the optics. The issue in these lenses, when you decenter the optics, is how to quantify and communicate the decentration to the lab. Some Scleral lenses provide a lens with laser mark and 8 meridians that help you quantifying the decentration. Next, please. A recent study presented at the last GSLS introduced a novel method for measuring and constructing decentered optics. So the software tool compares the concentric circle that defines the outer border of the distance zone with the pupil margin and calculates the distance in millimeter and the direction in angle of the optical center of the lens. Next, please. So in this case, the optical center of the lens is displaced of 0.5 millimeters toward 220 degrees relative to the patient's visual axis. So to position the displaced optics over the patient's visual axis, the optical center must be moved 0.5 millimeters and 180 degrees in the opposite direction. So in axis 40 degrees. Next, please. Another customization is again designing oval lenses. It's well known that HVID and limbus are oval in all patients. Next, please. So fitting.
I keep noticing this on all my patients, not only scleral lens patients. It's amazing.
Yes, every patient, also ortho-K patients, soft contact lenses patients. And it's a problem with ortho-K lenses for the centration and also in scleral lenses, important for the limbal area, limbal clearance. So fitting scleral lenses based on the HVID, so the horizontal visible iris diameter, the lens will land near the limbus in the horizontal meridian, but far from the limbus in the vertical meridian. This will lead, next please, to the creation of an excessive clearance inferiorly, and this will cause decentration, stem cell breakdown, prolapse, and discomfort. Next, please. On the other hand, if you fit the lens based on your vertical diameter of the iris, clearance will be optimal vertically, but the lens will touch the limbus horizontally, and this will cause epithelial bulli. So next, please. The corneal and limbal zone should be designed based on HVID and VVID, and this will generate an elliptical scale lens. Next, please. Okay, next. There are two possible designs for this lens. The lens may be full elliptical with a large landing zone in both meridians, allowing a better stability. Next, please. Or you can make the ovality only in the corneal and limbal zone. And here the landing zone will have different width in the vertical than that in the horizontal meridian. Next, please. These designs are explained in this article. Next, please. So as okay, it's your slide, Melissa.
Yes, so there are some new scleral lens diagnostic sets that are available brand new, and here's one of them. So the Boston site Scleral Fit Kit. Say that 10 times really fast. I don't think I can. There are 2 different fit kits, as you can see, each with 3 different diameters. And these kits are using the data-driven diagnostic lenses to fit that have that unique built-in scleral shape that Dottie was just referring to. So there are built-in oval optic zones, there's front surface eccentricity to control aberrations, and there's also the potential for HOA technology and the Fit Connect, which is the online ordering. And there's another new, this was a study that was recently published that looked at the clinical outcomes of scleral lens fitting with a data-driven quadrant-specific design. And I would encourage you actually to read this entire journal because it was just fantastic on all on scleral lenses and many fantastic studies in there. And another different diagnostic set is from Visionary Optics, the Elevate. So this is based on SMAP scans that I was speaking about earlier, a metadata-driven set, and there are quadrant-specific haptics in these diagnostic lenses.
Okay, so before I stated that all scleral lenses should be customized, I personally customize all my scleral lenses. I use a technique inspired by Dr. Greg Gimonis using the OCT for lens design. Next, please. So Hugo Legaria from Argentina introduced me to this method using SketchUp software. It has a pro version, but you can use it. You can use the free version, which is also available. Using this method, you have to upload an OCT cross-sectional image, but it should have at least one measurement to allow you to put it in scale and design the lens in scale. You need to take the capture of 2 meridians to make at least a toric lens, and you can design the posterior and anterior surface. Of course, it's not sufficient. Next, please. You need to make several calculations using different formulas for different parameters, and it's very time consuming. But this can be made easier by developing an Excel sheet. Next, please. Like here, what I did here, and this Excel sheet will facilitate all the calculations. So you only need to include your initial values, and the calculations are made automatically. For the lens tag, I use the steepest meridian for the calculation, and I can also have the sagittal height at different chords. Usually, I regulate the sagittal height at the primary functional sagittal height. Yeah, next, please. So with this method, it's possible to design very sophisticated lenses, such in this case, customizing the corneal area as well, making a quadrant-specific design in the corneal zone. In this case, I had to design a lens with a quadrant-specific design in the corneal zone with up to 700 micron of difference between all quadrants. Next, please. So yes, this method is helpful for those who cannot afford the technology. Technology customization is essential, and we know that different techniques are available. Costs have important impact. How many of us can afford this technology? We know that the economic situation and cost of scleral lenses are very different in various countries. So I'm talking about all in all over the world. Practitioners in all over the world. What is simply afforded in US, it may be difficult to have for practitioners in other countries, but we need to remember how much time in optimizing the lens and sheer time you will consume to get the final lens, and how much lenses you have to reorder to get the final lens in whatever country you are living. And how much money you will spend in reordering lenses, and your patient will travel to other countries to get that technology that is missing. Your patient will get stressed and perceive a non-experienced practitioner in you, and they would go to other practitioners to have the advanced technology. And practitioners who will find faster the final lenses will be considered as more professional. Patients will go to them even if they will pay the lenses slightly more expensive. So remember, patients from around the world ask for this technology. Next, please. So we need to customize every lens, make them different for each eye, not only for each patient. Each eye needs a different lens. Remember to allow tear exchange, as Melissa highlighted before. A looser fit is sometimes crucial for corneal health. With customization, we can have a full control on how much the lens may have a looser fit. So a customized lens, it doesn't mean a properly fit lens that seals the environment in the fluid reservoir. So with looser fit, we may have some debris influx with the tear exchange, but here again, the corneal health has a priority. It's the benefit-risk ratio, and we also need to start customizing the lenses in the corneal area and to correct high-order aberrations.
Dottie, I'm going to ask you a question that comes up often, and that is just about explaining to your patients. How do you explain to them how you're going to design a customized lens?
Well, I show them what I do, all the designs, the lenses. I show them the software I use. Now I will finally have in a few days my Pentacam, so I will have I will get a step further with technology, and I tell them what. I tell them the truth. I tell them what the diagnostic said, the lenses were certainly fitted on other patients' eye, and of course they are properly disinfected. However, it's never similar than having a virgin lens. Never applied to anyone before, and it will be the patient's own lens. I also let them know that there might be another issue. We know that with the new guidelines of handling diagnostic lenses, the lenses need to be disinfected for a significant time, and I may not have that lens available to fit the patient. So I tell them that I might need another similar lens, which will complicate and prolong the fitting process with additional lenses ordered. So I let them choose, and I tell them that I will reduce their time. I will reduce the stress for them, but this need extra cost, because actually I reducing that time, I'm saving fitting time, chairing time, and stress, but to do that I will spend more time myself to properly design a lens, and they need to consider so the cost of my time and the expertise in lens designing.
Excellent.
So I'm getting back to the present. Next, please. So yes, after all, your patient have to choose, but before your patient choose, you have to choose. Do you want to be a scleral lens fitter? Next, please. Or do you want to be a scleral lens tailor? This is up to you. Next, please. So now we have several valuable sources dedicated solely to scleral lenses. Next, please. And now just released a new book on how to manage scleral lens issues and complications depending on the etiology. Next, please.
And soon to come are the BCLA clear reports, including the scleral lens clear report with Dottie, which Dottie and I had the pleasure of working on. So we do want to thank you for your time, and we will answer questions as well. But please also sign up on Wednesday, March 3rd for the Scleral Lens Encounter from start to finish.
Well, thank you both so much. Fantastic lecture as always. We do have a number of questions here. We'll start out with Dr. Burnett, you had talked about allowing proper settling before evaluating a lens with an OCT. Do you have an average amount of time you allow settling before that evaluation takes place?
30 minutes would be great. And sometimes I'll actually write down the time that the scleral lens goes on. It sort of depends who I'm working with that day, but I find that to be helpful just to write down, 8:40 in the morning is when the scleral lens goes on, and I just see a few other patients and then get an OCT. But it is helpful because different patients have more squishy conjunctiva, more spongy than others. So it's nice to allow time. Of course, once you're fitting a lens design and you're really comfortable with it, you kind of get the feel of how much that's probably going to settle based on the diameter, based on the condition that you're fitting, whether it's corneal irregularity or ocular surface disease. But it is good to wait 30 minutes if you can. And then, of course, when the patient comes back for follow-up, having them wear the lenses 4 hours would be ideal, and checking OCT right away would be fine.
Yes, I agree. Half an hour is sufficient because recent research have showed that after half a minute, we have about 50% of lens settlement. So you have an overall idea on how the lens is settling.
Perfect. And then the next question. As far as we had a lot of questions on fenestration, is there a certain tolerance on corneal thickness to where you'll maybe start fenestrating, or certain symptoms or signs that are present when you decide this fenestration would be indicated?
Well, fenestration is indicated for several issues. For corneal edema, it depends on the corneal edema. If you can handle it with high TK materials or with a looser fit, that's okay. If the edema still persists, you can include the fenestration, one or more fenestration. It doesn't have a rule how much thickness of corneal thickness is to go to the fenestration. Depends on the corneal health and corneal conditions. You have to see each patient by individually and not have there's no rule for everyone.
And I totally agree with you, Dottie. Just one thing to add, if you can check the endothelial function, if you're concerned about that for these patients, that is helpful. Another recent patient that I fenestrated has a history of recurrent corneal erosions with scleral lens wear, and by making the lens a little bit looser and having her remove and reapply the lens once a day has helped, so she does not get the erosions. We want to look at the endothelium. We want to check for things like Fuchs corneal dystrophy, any sorts of pre-existing corneal edema. It's important to document that. And in these patients, I'm thinking, how do I want to design the lens maybe a little bit looser so that it's not causing any suction on the eye?
Well, yes, recently about corneal edema, I read something about the Clark-Chang rule, which I think it's genius. So what he does, he tells his patients to apply a lens on one eye, remove it after a few hours, 4 and 5 hours, I don't remember how much, and then apply the other eyes, the other lens on the other eye. So in this case, they will have a good vision with conserving corneal health.
But what if they're monocular? What if they only have one eye?
Yeah, it's monocular. One eye.
No, just one eye, one seeing eye. I'm joking. No, thank you, Clark. That's excellent advice, and thank you, Dottie, for bringing up. But I'm saying if they only have one functional eye, I feel like I have a lot of patients that only have one eye that they can see it.
Yeah.
So kind of to dovetail on using fenestrations for recurrent corneal erosions, we had some other questions about other indications for fenestrated lenses. Somebody asked about as a indication with midday fogging or extreme dry eye disease. Are there any other indications that you use fenestrations for besides corneal edema?
Well, fenestration are indicated also for patients having problems in applying the lens. The fenestrated lens doesn't need to be filled with the solution. You can fit it without solution. So for patients having problems in fitting these lenses, this may be helpful. For pediatric patients, very helpful as well. Also removing the lens for patients who have problems in removing the lenses. Fenestrated lenses do not create suction, so they are easily removed without any use of any plunger. And yes, I have this indication, a part of midday fogging and corneal edema. Yes.
Great. And then a couple more here. When you're using scleral topographers, is there any way to account for lens settling before the lens is actually applied to the eye when ordered empirically?
I'm sorry, Joe, I'm not sure if I understand the question. So we do scleral topography first, and then a diagnostic lens could be put on if you wanted to check the vision in over-refract. Maybe restate the question?
I think the question is there any accounting for settling when ordered empirically? In other words, do you do anything ahead of time too?
Oh, yeah. So each company does account for lens settling for sure, definitely. And I've spoken with several different companies that have different amounts of settling that they include. So both central and peripheral settling. Good point.
Yes. When I design my lenses empirically, I calculate about 350 microns of additional clearance to allow lens settling. In some cases, when I see already that the conjunctival tissue is most looser or soft, I calculate more about 400, 450 microns. But again, as Melissa said, it depends on the software that you are using, and the lens design. The diameter of the lens is important. So every company has its own amount of lens settlement calculation.
Perfect.
I would encourage practitioners to talk to the companies that they're working with and talk to them about the instruments that they're working with and actually going through specific cases, because they're quite knowledgeable, and it's been really helpful for me learning the different technologies by talking to the consultants at various companies.
That's great. We'll do one more. I think it was Daddy was talking about oval designs for the optic zone, and mentioned something about excessive limbal vault encouraging limbal stem cell deficiency. Can you elaborate on why that is?
Well, when you have excessive limbus clearance, the clearance is high in that area, and it will compromise the oxygen transmissibility to the stem cells, and it may compromise their health. It's because of the thickness of the clearance in that area. So we may have limbal edema.
Beautiful. Well, thank you both so much. This was an extremely informative lecture, as always. Thank you to everyone who joined us tonight.